Okay, today we will discuss endodontics definition, clinical features and morphology of the dental cavities and root canals, endodontic instruments, and endodontic techniques, the main endodontic techniques. First of all, I want to tell you about meaning of endodontics. Endodontology is concerned with the study of the form, function, and health of injuries to and disease of the dental pulp and the periradicular region, their prevention and treatment, the principal disease being apical periodontitis caused by infection. The etiology and diagnosis of dental pain and diseases are integral parts of endodontic practice. The scope of special area of dental practice known as endodontics is defined by the educational requirements for the training of a dentist. Endodontic treatment encompasses procedure that designed to maintain the health of all of part of the dental pulp. When the dental pulp is diseased or injured, treatment is aimed to preserve normal periradicular tissues. When apical periodontitis has occurred, treatment is aimed to restore the periradicular tissues to health. This is usually carried out by root canal treatment in combination with surgical endodontics. The scope of endodontics includes, but is not limited to, the differential diagnosis and treatment of orofacial pain of pulpal and periradicular origin, prevention of pulp disease and vital pulp therapy, pulp extirpation, and root canal treatment. Root canal treatment is in cost of apical periodontitis. A retreatment in case of post-treatment apical periodontitis, surgical endodontics, bleaching of endodontically treated teeth, treatment procedures related to coronal restoration by means of a core and/or a post involving the root canal space and/or endodontically related measures in connection with crown lengthening and forced eruption procedures and treatment or traumatized teeth. I think that all of you understand that endodontic treatment can't be without knowledge of dental anatomy and anatomy of dental cavity. Please you have to separate the two terms, caries cavity and dental cavity. I think that all of dentists have to understand that caries cavity, it is abnormal cavity which exists in the tooth, though the demineralization is a pathological process in the enamel and in dental cavity, it is normal part of each tooth. It is anatomical space into the tooth which has the pulp. Please put your attention on the slides. You can see the main structural parts of dental cavity. It is the pulp. You can see the pulp situated in the dental chamber. The pulp situated into the dental chamber. There are three clinical and anatomical parts of the dental pulp or dental cavity. It is pulp horn, root of pulp, floor of pulp, very important clinical and anatomical area or zone, orifice from to canal, and the root canal. You can see accessory canal, and you can see the apical foramen. Please remember about this. And on the next image, you can see The shapes of the dental cavity, which situated in the coronal part. Dental cavity with the orifices of the root canal. And then next, pulp chamber morphology. I want to tell you about important general consideration of pulpal anatomy. First of all, it's a shape. The shape of the coronal pulp and the outline of the canals is a reflection of the outline of crown and root surfaces. Pulp morphology, these are with age, irritants, attrition, caries, lesion, abrasion, and periodontal disease. What about root anatomy? I want to tell about general features of the root anatomy. Our 90% of roots are curved. You can see this zone of the roots on the slide. The only root that rarely, it ever, contain two canals, a maxillary anteriors, maxillary premolars with two roots, and the distal buccal and palatal roots of maxillary molars. All other, note this includes all mandibular roots, may contain two canals. Apical anatomy, don't forget about apical foramen. Each root ends with apical foramen. Apical anatomy changes with age. The apical constriction is variable and usually cannot be detected by tactile sense, especially early in preparation. As dentine lay down in the coronal third of root canals with replicose spines to bind coronally before they reach the apical third of the root canal. Planes of curvature. Radiographs from a labial buccal projection show only two planes of curvature. Many curvatures are towards or away from the field. For this pupa, this exists another methods of investigation is the 3D modeling. You can see the results which the dentist can lead after 3D modeling, computer 3D modeling on your screen on the slide. Please put your attention on this. You can see the first image. Shows you the routine methods of dental investigation through X-ray radiography. And the next image can show you the 3D modeling. It's lower molar and upper premolar. It is, for example, access to the root canal system involves both coronal access to the pulp chamber and radical access to the root canals, though the root canals orifices. Coronal access. The coronal access preparation in root canal therapy serve several important functions. It provides an unimpeded path to the root canal system. It eliminates the pulp chamber root in its entirety. It is large enough to allow light and enable examination of the pulp chamber for root canal orifices or fractures. Please put your attention on the slide. You can see the 3D modeling, you can see the theme, and you can see the photo with the pulp chamber, coronal part of the pulp chamber. two types of access you have to remember: coronal access and access to the root canal, though the root canal orifices. Pulp chamber morphology, different types, different variants of quantity and localization of the root canal orifices. You can see on this slide, it is molars, and you can find from 3 to 4 root canal orifices. You can see the correct access to the root canal orifices on the slide, because you can see these anatomical areas. The ideal access cavity will achieve the above objectives, but will preserve as much sound coronal and radicular tissue as possible. However, it may be necessary to enlarge and deflect the access to enhance the preparation of root, and especially curved in their coronal third. In this situation, access preparation is dynamic, developing as instrumentation progresses. After making the access to the pulp chamber, coronal part of the pulp chamber and the root canals orifices, or the endodontist have to make a radicular access. The principle of straight line radicular access cannot be allows instrument to flow down the cavity line angles into the apical third of the root canal system without interruption, and provides maximum tactile feedback while instrumenting the most delicate apical portion of the root canal. Adequate straight line access reduces the angle of the curvature in the coronal thirds of the root canal, where it exits from the floor of the pulp chamber, and thus reduces the overall canal curvature. Further advantages will be discussed later. Access to the root canal system is aided by examination of coronal anatomy, tooth position and angulation, external root morphology. You can investigate with the help in the routine X-ray examination or X-ray investigation. The preoperative radiograph of preferably more than one taken at different angles. It is necessary for the correct investigation of the quantity and the shape of the roots. It is necessary if you want to get the access to in the molars, upper molars, and upper first premolar. Examination of the tooth will provide guidance to the position, side, and angulation of the access cavity as teeth is diluted in one or more planes relative to the arch and adjacent teeth. Examination of the radiograph affords information on the size of the pulp chamber, sorry, something happened with the presentation. The size of the pulp chamber, the distance of the chamber from the occlusal surface. Would you put your attention on the slide on the occlusal surface? And the floor of the pulp chamber in the coronal part. the angle of exit of root canals from the floor of the pulp chamber. This provides an indication of amount of coronal third root canal modification required to obtain straight line access. Straight line access before the beginning of the curvature. Endodontic access openings, incisor and canine teeth. Incisors and canines have one root and one root canal. The access cavities for maxillary central and lateral incisors are similar and generally triangular in shape. Access cavities for maxillary and mandibular canines are almost identical and more ovoid in the shape. Access for mandibular central and lateral incisors are triangular in shape, and a second canal may be present in 40%. In general, extend the axis in dental teeth toward the incisal edge and under the single premolar teeth. The maxillary first premolar in most individuals contains two canals and is extended more buccolingually than is single-rooted premolars. Approximately 5% may have a third root canals placed buccally. In such situation, the axis will be triangular in outline with the base toward the buccal side. You can see all what I say on the screen on the slide with maxillary and mandibular teeth. The maxillary first premolar, the maxillary second premolar, and both of the mandibular first and second premolars usually have one centrally located root canal. However, in the canal appears to be situated under either the buccal or lingual cusp. Look carefully for a second canal under the opposite cusp. The opening is a narrow oval shape. The maxillary second premolar axis is centered over the central groove. Axis for mandibular premolars is buccal and and to the central groove. You can see once more. I tell you about this all what I say on the screen. Please put your attention to the first scheme. The maxillary molar axis is generally triangular in shape with the base to the buccal and the apex to the palatal. Usually one palatal and two buccal canals are identified. However, two canals may be present in the mesobuccal root in 90% of cases, with approximately half ending in two foramen. Premolar teeth. The maxillary first premolar is most individual. The mandibular. The mandibular teeth. The mandibular molar. The mandibular molar's axis is more trapezoid in shape with a space to the mesial and apex to the distal. They usually have two roots with two canals in the mesial root and one in the distal root. There is possibility of a second canal in the distal root. Mandibular molars. Please remember that mandibular molars have two roots but three root canals. It's very important information for all dentists. Remove as much restriction techniques. Now we have to discuss the techniques of access, and we will discuss the instruments which all dentists can use in the practice, in the further practice. First of all, about the coronal access. It is necessary, the dentists have to remove as much restoration is necessary prior to entering the chamber in order to reduce the likelihood of filling materials entering the canal system. Remove all temporary materials, restore broken down teeth with different dental materials, a band to help rubber dam isolation and ensure a forward access cavity. Crown lightening may be necessary. Extract undestroyable teeth. Remove all caries prior to entering the pulp chamber. Full coverage crown and frequently not orientated to the original tooth anatomy. Study radiographs carefully prior to commencing access to see if the tooth may be rotated. Also check external root anatomy. What about isolation during the endodontic treatment? The best isolation the dentists can provide though the rubber dam. It's a simple and correct isolation for the all endodontic manipulations. Please let me tell you a few words about the rubber dam, its function and methodic of its supply. The rubber dam is essential for root canals treatments and efforts the following advantages. Asepsis, prevention of saliva contamination, improved visibility, soft tissue protection, confinement of excess irrigant, reduced liability of the collagen dents. It may be deemed appropriate to initiate access prior to placement of rubber dam, and this allows better appreciation of external root contour and tooth position. The rubber dam should be placed as soon as the pulp chamber is identified for the above reasons. Access techniques. The access cavity is outlined provisionally. Provision on the tooth and progress is directed pulpally, constantly being mindful of the depth of root penetration into the tooth. A round-ended burrs is to be preferred, and the flat-ended ones goes to access cavity walls. It is wise to compare the depth of penetration of the burr to the apparent pulp chamber depth on the preoperative radiograph. If there is vital pulp tissue, gamma rage, removed to the coronal pulp with the excavator and or radical pulp with broaches and irrigate with the sodium hydrochloride, as good visibility is important. Dentist has stop and take radiograph of the canals. Place and Endodontic Explorer. In the hole you have prepared, ask the patient to bite on it and take radiographs from original anatomy and foramen position maintained. The apical foramen should also be kept as small as practical. On the slide, you can see instruments for access cavity preparation. This instrument allowed the dentist to access the coronal part of the pulp chamber without complications such as perforation, for example, the wall of the pulp, of the distal or mesial, walls of the pulp chamber, or another complication such as perforation of the pulp chamber wall. In summary, the aim of the root canal preparation is to debride the pulp space, rendering it as bacteria-free as possible, producing a shape amenable to irrigation and obturation. This apparently task is complicated by the anatomy of root canal system, which is complex and makes cleaning them in their entirely a clinical challenge. Current trends in canal preparation. Current thinking on canal preparation emphasizes the development of shape in a ground-down manner, removing infected dentine as it is encountered. Further cleaning of the canal is provided by correct choice and use of root canal irrigants, in particular sodium hypochlorite, because of its antimicrobial and tissue dissolving properties, with the combination being termed chemical debridement. Instrument manipulation. Before discussing the instrument manipulation, I want to show you the instrument for access dental cavity the instruments for access to the orifices, root canal orifices. The previous slide shows us the burrs, the special burrs for access to the root canal orifices. The next instrument, it's gaze glidden burrs, let the dentist get the access to the root canals. These instruments the dentists use during formation the access in the area of orifices. Instrument manipulation. The two most commonly used motions and balance force. Balance force. In many ways, the development for balance force involves rotating instrument clockwise to set the flats and the rotating. Balance force is an efficient cutting motion and has been shown to maintain a central canal position. Even round, moderate curvatures will allowing allied sides to be prepared apically compared with other hand instrumentation techniques. Coronal interference. This influence the force a file will extend within a canal. This is of particular importance in curved canals where files may prepare more dentine along the focal dental zone as opposed to the other canal wall. It is important to be aware of this to limit the size of enlargement in curved canals and direct files away from the focal wall to avoid a strip perforation. Irrigating. What about irrigating solutions? Irrigating solutions are usually delivered using a syringe with a 27 or 28 gauge needle. Care should be taken to ensure that the needle does not bind in the canal and that irrigating solution does not pass into the periapical tissues. The role of the irrigant is to remove debris and provide lubrication for instruments. Specifically, an irrigant such as sodium hypochlorite will dissolve organic remnants and, most importantly, also has an antibacterial action. It may be used in the range of concentration from 0.5 to 5.25%. With 2.5% being popular. It is important that the irrigant is changed frequently. Ideally, irrigation should be performed between each file, at least every 2 to 3 files being the minimum. If removal of the smear layer is desired, then irrigation solution containing ethylenediamine tetraacetic acid should be used. There is no clinical consequence as to whether or not the smear layer should be removed, although there is a suggestion that its use may have a positive effect on the outcome and retreatment cases. The most effectively way of delivering irrigating solution is though the ultrasonic handpiece. You can see the irrigation, the needle for the root canal irrigation, and you can see the ultrasonic handpiece. Ultrasonic agitation has been shown to be effective to removing debris from canals. Canal preparation. Several methods of canal preparation exist. The method described here in comparison current though. Canal exploration, pre-enlargement when necessary, straight line radicular access, lens determination, working lens determination, and apical thirds preparation. It is the main stages of root canal preparation. Canal exploration. Root canals are infinitely variable in their shapes and sizes. Larger canal allow easy placement of instruments and irrigating solution, whereas small ones require pre-enlargement coronary prior to the canal exploration. Preliminary assessment of the canal can be made with the smallest and most flexible instrument. It is unlikely that the operator will be able to determine the working length. Initially, the files may be bending coronally. A pre-enlargement and straight line radicular access. For the small canals with curvatures exists the next type of instrument I can show you on this slide. It is knee-T flexophiles. It's with the memory shape. It is the best instrument for the access and instrumentation of small root canals with curvatures. Pre-enlargement is achieved by watch winding file size from 10 to 45 in series, gradually opening up narrow canal orifices to a size sufficient to take a gaze gliding bore. I showed you the gaze gliding bore for formation the access to in the root canal orifices area. The pre-enlargement can the pre-enlargement can then be development further to produce straight line radicular axis, taking care to walk the bar away from the focal regions of roots. I think that I have to show you to come back to the first slides and show you the zone of vocation. This is zone of vocation. In this zone, the 2 or 3 dental roots separate from different anatomical structures. A file should stand upright in the tooth and pass uninfected deeper into the canal once adequate straight line radicular axis can have been achieved. Gates grading may be used to relocate a canal away from the danger zone. However, care should be taken to avoid over enlargement. Gaze bleeding number 6 or 5 should only be used on the walls of the access cavity, and number 4 no deeper than the canal orifice. The number 3 may be used to the mid-canal region, and the number 2 the beginning of the canal curvature or 2 near full lengths in a straight canal. The number 1 is quite fragile but may be used in ultra slow speeds provided it is loose in the canal. Advantages of pre-enlargement and establishment of straight line axis. There are a number of advantages from achieving straight line axis. It creates sufficient space to introduce files and irrigating needle solution deeper in the canal. The bacteria count in the more coronal aspects of the canal is reduced. A reservoir of irritant and created the files path though as they move apically. The increased space allows files to fit passively in the canals, making inoculation of infected material into the periapical tissue less likely. And generally, the principles of root canals treatments consist of thorough cleaning, adequate shaping, and complete filling of the root canal system. In order to accomplish these objectives, many different instruments are available. Though of the instruments are common to all branches of dentistry, while others have been modified or specifically designed for endodontics. Endodontics instrument is the instrument which ICO. It is International Unification instruments. Basic instruments. A basic selection of instruments should be packaged or set up in a tray ready to use. A flat surfaced mount mirror produced an undistorted image of good visibility deep within the pulp chamber. The Endodontic Explorer is a double-ended, extra-long, sharp instrument designed to help in the location of canal entrances and for detecting fractures. A long spoon excavator is required to remove pulpal content and soft caries where present. Locking tweezers are ideal for handling paper points, gutta percha points, cotton wool pellets, and root canal instruments. Both broad and periodontal probes are necessary for the initial assessment of the tooth for caries and the localized periodontal condition. A flat plastic instrument and an amalgam plug are needed for placement or an inter-appointment restoration. A millimeter ruler or other measuring devices should be available for measuring purposes. A surgical hemostat may be used to position X-ray film for radiography during treatment. And once more, I want to tell you about isolation. I told you a few words about rubber dam, but for the positive results of endodontic treatment, the dentists have to begin this procedure from the placing of rubber dam. It is I'm sorry, it's another slide. It is a prerequisite that the bones being treated must be isolated. This is effectively and efficiency achieved by the use of rubber dam. There are many good reasons for using rubber dam. It protects the patient from inhalation or ingestion of instrument, medicaments, and debris. It prevents infection by providing a clean, dry, aseptic walking field, free from salivary contamination. It allows to retraction of soft tissue, and it also with no obstruct the operating field and also protect them from injury. It enhances excessive therapy, improving the efficiency of treatment. It provides better patient comfort without the oral cavity being flooded with water and or debris. Hand instrument. After the isolation of the walking field, the dentists have to use hand or machine endodontic dental instrument. Hand instrument you can see on this slide. A scheme of the hand instrument you can see on this slide. Hand instruments are grouped according to usage and to the classifications. This slide into the classification established by the International Organization for Standardization, ISO. The terminology, dimensions, physical properties, measuring system, and the quality control of endodontic instruments and materials are defined by this standard. As a result, endodontic hand instruments, that means file, reamers, and barbed broaches, are standardized in relation to size, color coding, and physical properties. The relevant information on sizes and color coding for files and reamers are listed by the table, which you can see on the screen. The tape is a constant 2%. 2% for 1 minute. The files intended for 2% or 2% or 2 millimeter of cutting plot. Hence, also referred as the 0.02 taper. The shape of the tip is variable. The lengths of instrument available are normally 21, 25, and 31 millimeters. Endodontic hand instruments have reamers. And I'll show you this instrument. Reamers are manufactured twice in a taped stainless steel blank to form an instrument with the shaped cutting edge along the spiral. They are used with a half-turn twist and pull action, which shapes the canal wall, removing dentine chips from the root canal. Nominally, they have a triangular cross-section, but their smaller size may be manufactured from a square blank. This is reamers and files. There are various types of root canal file, and they are mostly made from stainless steel. Files are predominantly used with the feeling of rasping action, in which there is little or no rotation of the instrument in the root canal. The properties of different files are related on their design features. The common types of files are K-file, K-flexifile, K-files, K-flex files, flexifiles, and headstone files. You can see on the screen the endodontic instrument, which has type K-type, which have K-type, and endodontic instruments, which have H-type or H-file or headstone file. K-file. This file is so named as it was introduced by the care company. These files are made like reamers, but twisting a triangle or square blank, but in the series of spirals to produce from 0.9 to 1.9 cutting edge per millimeter length. They will work either in a reaming or a push and pull filling motion. K-flex file. The K-flex file was developed in an effort to improve on the original K-file design. It has a rhomboid-shaped cross-section. As a result, when the lens is twisted to form the instrument, it has a series of cutting flutes with alternate shape. Cutting edge are obtuse, non-cutting edge. The height and low flute configuration is designed to endo the instrument with greater flexibility and provide a reservoir for the dental debris. A disadvantage of the K-flex file is that it tends to lose its cutting efficiency quickly. Flexifile. This file is manufactured by the same film in the same way as the K-file, but using a more flexible stainless steel alloy. The alloy used in file manufacture has a breeding on its cutting efficiency and resistant to fracture. The main complication after endodontic treatment, it's a fracture of the endodontic instruments. The flexifile has non-cutting tip and a triangle cross-section, though the cutting flutes are shaper and there is more room for debris removal. It was reported to produce good instrumentation results. What about headstone file? The headstone file is made by a milling process from a steel blank of round cross-section to produce elevated cutting edge. You can see this cutting edge on the screen. The tapering effects appears to form a series of intersecting cones. This is intersecting cones. Although their design leads to a sharp and flexible instrument, the flex is inherently weaker due to the reduced shaft diameter and it therefore slightly more prone to breakage. It is the most effective when used in a pull motion. With sharp cutting fluids, it's also used to enage and remove retained instruments, gutta percha, and in other points. What about NIT instrument or nickel titanium instrument? There have been a number of developments in instrument design and technology. Instead of stainless steel, nickel titanium alloys have been introduced in the manufacture of endodontic instrument. And NIT files, it's a widespread in dental endodontic instruments. NIT alloys have been introduced in the manufacturers of endodontic instruments. The NIT alloys have many interesting properties: shape memory effects, ability to return perfectly to its original shape. You can see on this scheme how the NIT flexophiles can return to its original shape after usage. Super elasticity, low modulus of elasticity, good biocompatibility, and high corrosion resistance. The concept of using NIT for endodontic instruments came from orthodontics, where its properties have been utilized and the archwires of fixed appliances. The NIT alloy used to a root canal instrument is known generally as nitinol. Nickel for nickel, T for titanium, and NOL for Naval Ordnance Laboratory. The manufacture of NIT endodontic instrument is more complicated than that of stainless steel. The majority of the instruments are machined. Compared with stainless steel, NIT instruments have greater flexibility in bending, in better resistance to torsional fracture. NIT instruments have a non-cutting tip, and they cannot be easily curved. Their cutting efficiency is dependent on cross-sectional shape. Straightening curved root canal less than stainless steel instrument, producing a more central, tapered and acceptable preparation. They also have different wear characteristics compared with stainless steel instrument. And the cutting efficiency of this instrument depended on cross-sectional shape, but is less aggressive compared with the stainless steel instrument. This instrument very useful when you want to instrumentation, to have provide instrumental stage of root canal preparation. Power assistant root canal instrument. What that means? Many different power assistant root canal instruments have been developed over the years in the hope of making root canal preparation quicker and to reduce operator or dentist's fatigue. Reciprocating hand pieces. These handpieces impart a mechanical action to the root canal instruments to cut dentine. And early examples of the geomantic mechanized handpiece in which the continuous rotation of the driver's shaft is transformed into a alternating quarter-turn movement of the files. Later examples in the push button type chuck mechanisms to accommodate plastic handle root canal instrument. The handpiece imparts a watch winding oscillatory movement to the attached root canal instrument. On the screen you can see endodontic handpiece, the modern endodontic handpiece with the apex locator. What is the apex locator? I told you soon. Rotary NITI instruments. With the advent of instruments made from NITI, the endodontic market has become dominated by many new rotary root canal instrument systems. Many consist of a combination of rotary and hand NITI files. It is impossible to detail all the different rotary NITI systems, but many novel and unique design features have been incorporated by manufacturers. Variable taper or meshing files. The concept of taper variation is to maximize the cutting efficiency by minimizing the contact area between the surface of the instrument and the canal wall. Instead of having to flare a canal using different different types taper files to achieve the desired shape, the preparation is produced by using files of the desired taper straight away. The larger, the more conical the shape of the instrument. For ease of use, many rotary instrument systems have matching variable taper hand files, paper points, and good aperture points. Flute design. The shape of the flutes in cross section determines cutting efficiency and their ability to remove debris. A design incorporating a reservoir of the dentine debris will help effective evacuation as the debris is transported horizontally. Rake angle. The rake or cutting angle, what that means? Active part with the cutting angles. With some quantity of the cutting angles. The rate of cutting angles of most conventional instruments is negative, though the cutting blade scribes rather than cuts the dentine, and this is inefficient. A positive rake angle results in more effective cutting, but if the rake angle is excessively positive, the cutting blade will dig into the dentine substrate. Therefore, the rake angle should be only slightly positive. A helical flute angle. This is the angle at which the cutting flutes spiral around the shaft of the instrument. If there are too few spirals, the entire debris will accumulate quickly before being removed, and the instrument will become clogged. On the other hand, if too many spirals, the entire debris has too great a distance to travel before being evacuated, and functional resistance may trap and compress the debris. The ideal helical flute angle allows efficient removal of the entire debris without clogging the instrument. Also included in the helical flute angle along the length of the file from the tip to handle, assist in debris removal. Core diameter of fluid depth. The core strength and flexibility of an instrument is dependent on its core cross-sectional diameter. The large and core diameter, the more robust and rigid the instrument. The core diameter is inversely related to the fluid depth. The proportion of the core diameter to the outside diameter should be greatest at the tip, when strength is more important. By uniformly decreasing the portion, the flatten moves up the taper, resulting in greater fluid depth. The flexibility increases while the strength and instrument is maintained. In an additional advantages is that the entire debris is also removed more efficiently. And please put your attention on the slide once more. There are the main parts of the machine files or mechanical endodontic instruments. You can see it's a handle, it's a measuring lines, and is an active part. Deep or penetration or wide. Technically, endodontic treatment of teeth comprises three main phases that may be of equal importance for the outcome of the treatment. The three phases or stages are preparation for treatment, root canal instrumentation, root canal obturation. Few words I have to tell you about instruments for the root canal. Sorry, about the properties and advantages of the instrument. You can see on the slide the variants of dental anatomy. Dental root anatomy, and please put your attention on the apical part. For these aims exist the different NIT Lexa files which can lead to the correct root canal instrumentation without appearance of the different complications, such as fracture of the instrument or perforation the root before the root curvature. In the last decades, it has become common practice to use an operating microscope during the various phases or stages of endodontic treatment. The microscope offers magnification, but almost as important, it gives excellent light directly through the lenses into the access cavity. That gives the operator tremendous advantages, especially in difficult cases. And in straight root canals, it is possible to observe the canal all the way to the apical foramen. Preparation for treatment. Preparation for endodontic treatment entails the establishment of the root canal to be treated in an antiseptic field of operation. It consists of the preparation of an adequate access cavity, the secure placement of rubber dam, and the disinfection of the rubber dam, the tooth, and the pulp chamber. Access cavity, more detailed information. The objective of the access cavity is to provide as unobstructed and access to the root canals of the tooth as possible. When misshapes occur during the instrumentation and obturation phases of the treatment, they can most frequently be attributed to an inadequately or incorrectly prepared access cavity. The most common mistakes is an access opening that has been made too small. As a result, canals are missed or the manipulation of the root canals instruments is unnecessarily pulps horns. Unnecessarily hidden by the cavity walls. Also, tissue may be left behind the coronal pulp, especially in the pulp horns, leading to discoloration of the tooth. On the other hand, tooth structure should not be removed indiscriminately, that would lead to an unnecessary weakening of the tooth and would complicate the restorative procedures. The access cavity should expose to entire pulp chamber, including the pulp horns. In addition, cusps may have to be reduced to provide proper access to certain canals or to prevent uncontrolled fractures if they are weak. Before the preparation of the access cavity begins, a good radiograph of the crown of the tooth taken with a long cone paralleling technique is studied. Especially the distance from the occlusal or incisal point of reference to the roof of the pulp chamber is noted. This distance may be made on the board to be used for the preparation of the crown to the pulp. Carriers dentine is always removed, and filling the restoration with mind prevented direct view to the root canals are removed as well. Also, all undetermined cusps and are reduced at this time in order to prevent crown root fractures with mind the treatment of the root. For the actual penetration of the pulp chamber, a long shank-round carbide bore is used in a low torque ultra-speed handpiece. A long sharp bore is no necessary use because of the distance to be penetrated, but more because it allows for better visibility and better possibility of angling the burr correctly in relation to the long axis of the tooth. Porcelain crowns are penetrated by a standard length round diamond coated burrs, and the access cavity is then finished when the long shank carbide burr. When the penetration to the pulp has been achieved, the root of the pulp chamber is removed by pulping stroke with the burr from the chamber in an occlusal or incisal direction. It is where the entire pulp chamber is exposed without overage of occlusal tooth substance and without danger of perforation laterally or in the bifurcation region. The coronal pulp tissue, vital or necrotic, is then removed. A round burr may be used with advantage to ensure complete removal of tissue in the pulp core areas of incisor teeth. A double-ended endodontic explorer, which offer two angles of probing, is then used to locate the orifices of the root canals on the floor of the pulp chamber. The use of the explorer will also indicate whether the access cavity is adequate or whether, as is often the case, a cavity will has to be fried more or a cusp to be cut to improve the access to the canals. Often will be evident clinically and radiographically that root canals is classified on the orifice area. The microscope is then extremely useful. Sometimes a rigid explorer may be used to penetrate the calcified material. Other times, a long sharp burr is used to remove hard tissue to explore the canal. Since the exact location of the root canal is not always known, the brush is used with careful shaving motions in the orifice area. The explorer is used at fragment intervals of an effort to break through the calcified tissue. Exact placement of a 37% phosphoric acid gel for 60 seconds on the calcified orifice may be helpful as well. The access cavity preparation incomplete when the root canals have been located and are accessible for treatment or in non-vital teeth with ischemic necrosis. The pulp may be extirpated using the same method. However, in teeth with liquefaction necrosis of the pulp, there is usually so little tissue in the root canal that an expiration as such is not feasible. Rather, the tissue remnants will be removed during chemomechanical instrumentation. The chemomechanical instrumentation, the principles of goals of the instrumentation phase of endodontic treatment are the same regardless of instrument or technique used. However, the actual preparation of the canal may vary depending on, among other things, a step-back preparation. There are three main types main variants of endodontic techniques or preparation of the root canals. These three main variants you can see on your screen. It is anatomic endodontic technology. AAT is a minimally invasive endodontic preparation system. It's a crown down technique and step back technique. The two last techniques it is a standard or classical endodontic techniques. AET technique, it's a modern or contemporary technique of the root canal preparation. First of all, I want to tell you about step-back preparation and ground-down preparation because these are the classical and standard techniques. Step-back preparation. With the step-back technique, the diameter of the root canal at the apical level of instrumentation is kept as small as possible to resist extraction of filling material beyond the canal. In addition, the apical part of the canal is given a moderately tapered from an attempt to retain the obturating material within the canal. Furthermore, the canal is flared as much as necessary according to the anatomy of the canal and to facilitate the obturation of the canal. The flare of the canals is especially pronounced with the use of thermoplasticide gutta-percha obturation techniques, which require the insertion of rather large and rigid instruments to the apical region of the canal. The degree of instrumentation most apically in the root canal is determined by the size of the first K file that binds in the canal in the apical level of instrumentation. The canal is then enlarged an additional 2 instrument sizes at this level. This means that if a number 15 file points, the canal is enlarged to a size 25. The last file used most apically in this instance, number 25 is called the master apical file. The apical taper is then accompanied by a step back use of instrument of increasing sizes. Between each change of file, the full length of the canal is recapitulated with the master apical file. For the canal the canal is then floured with hand or engine drive instruments to give in the desired continuous tapered shape. The step back technique can be used in ETs, however, if the root canal is wide apically so that little natural resistance is offered, a more definite shape might have to be prepared in the canal wall to help prevent overfilling during the obturation phase. After when step back technique is used, it must be remembered that the root canal in many teeth is considerably wider in a buccolingual than as a mesodistal direction. The first instrument that binds will do so in the narrowest part of the canal, and an enlargement of 2 or 3 instrument sizes, which most often means from 10 to 15 millimeters. May not be enough to read the walls and the widest part of the canal. Those tissue commonly is left behind apically with the step back technique, especially on the lingual aspect of the root canal wall. Apical box preparation. An important result of morphometric studies of the root canal of human teeth, canals of human teeth, is that apically the canals may be wider than assumed and should be enlarged more than has commonly been done in some groups of teeth, like the incisors, considerably more. The apical box preparation techniques was developed with this information in mind. With this technique, one attempts to give the apical 2 or 5 millimeter on the root canal a cylindrical shape rather than tapered shape of the step back technique. In this way, it is hoped one can obtain clean walls consistently in the important apical part of the root canal. K-type instruments obtain clean walls consistently in the important apical part of the root canal. K-type instruments are used with filling and rotary cutting action. Stainless steel file size from 8 to 20 and nickel titanium file size 25 and up. Further currently, the canals is flight to a continuous taper with heads from files or in engine-driven instruments with their step-back techniques. The apical part of the root canals is open with a K file used with feeling motions until the file moves freely in the canal. The file is then rotated with its tip in the exact working length to be making a shell in the root canal wall. The next size file is introduced into the canal with twinning motions until the tip has again to the exact apical level instrumentation. The instrument is then carefully rotated, or if it necessary, used with the feeling strokes first until it can safely to be rotated in the desired apical level. The preparation of the apical part of the canal continues systematically with filling and reaming action until the canal is enlarged 2 to 3 instrument sizes. The canal then flared, beginning with a headstone or enjoined driver file, one side smaller than the least instrument used apically. The patency of the apical part of the canal is checked at regular intervals during the flaring of the coronal part of the canal. When the flare is considered adequate, the preparation of the apical part of the canal is completed with the K-tape hand or enjoined driver instrument, again mainly with rotary cat in action. In this way, a shelf is prepared in the root canal wall at the apical most level of instrumentation. However, due to non-cutting tip or modern root canal instrument, the apical shelf will be not abrupt, but rather have a sloping form. Still, the shelf constitutes as effective apical stop, again with a mastic departure point of the same size. The final apical instrument can be seated. Also, things to the final apical instrumentation is carried out with the rotary cutting actions. The apical part of the root canal will, if it is possible, have taken on the shape of a cylindrical box. For the determination, the working length of the root canal, dentists have to use the apex locator. This apex locator can mix with the endodontic handpiece or will be separate apparatus, leads to understanding the depths of the instrumental situation in the root canal and help the doctor to determine the working lengths. Working lengths mean the distance between the orifices of the root canal and physiological apical foramen. I think that you know about rentgenological apical foramen, anatomical apical foramen, and physiological apical foramen. It is the dental anatomy. I think that you have the knowledge about this clinical and anatomical features in apical foramen morphology. The next type of technique, it's a crown down technique. It's a standard classical endodontic technique. A series of instruments of decreasing size of taper are used in the ground down technique. Each file reaches deeper into the canal. In this way, the next smaller or less tapered instrument cuts deeper apically than the previous one. The repetition of such a sequence results in deeper access within the canal and or further enlargement of the canal diameter. The particular problems of taper lock occurs if within the ground down sequence only the instrument size is varied while maintaining the same taper. For this reason, the letter should also be varied more often. The variable taper or pro-taper instruments helps avoids this risk. The ground down techniques minimize the coronal interference, simplifies instrument penetration, increases apical tactile sensitivity, reduces canal curvature, minimizes working length changes during preparation, and allows penetration of irrigating solution down to the full depth of the preparation, which reduces bacterial accumulation before apical instrumentation. Thus, the ground down technique minimizes potential iatrogenic apical contamination, reduce the area of contact between the instrument of the canal wall, so reducing torque, increases cutting efficiency and safety, and reduces the frequency of procedural error. The hybrid concept of nickel-titanium rotary instrumentation. For any given root canal, a use of a specific instrument or instrument X or a certain techniques Y will not necessarily be successful. This is because the various endodontic systems on the market have quite different characteristics that may or may not deliver the expected in a given situation. Quite different characteristics that may situation depending on the root canal configuration. Within these specs is embedded the idea of the hybrid concept. Depending on the individual root canal anatomy and the associated special difficulties, the root canal preparation must be carried out with a logical and reasonable instrument sequence, which ideally has been selected for the individual clinical situation. The hybrid concept has previously has been published in parts. The illustration within this chapter provide examples in increasing levels of difficulty, as well as a description of the hybrid sequence used in each case. The ultimate clinical goal is a predictable treatment outcome with ideal preparation and without procedural errors. It is regard various types of instruments of various sizes and various techniques are used together in order to combine their advantages to eliminate as many disadvantages as possible. This demands knowledge about the cutting characteristics of the various instruments. Help to understand a hybrid sequences. The clinicians must be aware of the most important characteristics of the various instrument system. For example, nickel titanium system or basic types system files. The main the slowest recommended speed appears to be the safest. Always lubricate neatly rotary instruments, for example, with RC prep jelly. Ensure they are in the support of their clinician's hand to compensate for patient movement and for the better control of the instrument, and also to reduce their chewing in effect. Ensure conditions, continuous irrigation, fluiding of the root canal with the sodium hypochlorite or another antiseptic solution during root canal preparation. Minimize especially apically directed pressure on the instrument. Permit the instrument to continuously rotate from introduction to the canal until removal. Minimize the cutting time. Immediately withdraw the instrument on reaching their desired length. Each new introduction of the same instrument should penetrate more deeply into the canal. Following the removal of each instrument should be cleaned and inspected and replaced as necessary. Following the use of each instrument, the canal must be thoroughly irrigated, recapitulated, and re-irrigated. Apical patency must be regularly confirmed or checked. These rules are more critical for actively cutting instruments than for passive ones. Use of active as opposite to passive instruments leads more readily to procedural errors. errors, especially in inexperienced hands. Before clinical use, every new instrument system must be tested by practicing or extracted teeth. It has been shown that the frequency of fracture and deformation of instruments is reduced with increased clinical experience. To the end of this lecture, I want to tell you about the last class of endodontic instruments. It's instruments used for root canal obturation. For these aims, the dentist can use lentillar spirals, spreaders, pluggers, condensers, head carriers, and thermomechanical compactors. About material for filling the root canals, we will the material which you can use for the obturation, for the root canal obturation, will be discussed on the next lecture. Thank you for attention.